Welcome all. Welcome to IS Pharmacology Difficult Weekend Classroom. Well, this is the classroom where we will be discussing and revising whatever we have done in the whole week. Actually, it's a sort of a revision, and weekday wise, I'm taking the podcast titles, the podcast headings we have been doing from Monday till Sunday. So it will be every Sunday weekend classroom where we will be talking about or revising or summarizing things which we have covered in the podcast titles from Monday to Sunday. I hope it finds of good use to all of you, and these are all the you find it all the compiled up things at one place. So that is the purpose of this weekend classroom, and hope it benefits to all of you, and you can just quickly summarize what we have been through, and in case you want to revise a special topic you can go back to the podcast episode. So as you can see, the purpose of the weekend classroom is to revise, then to learn, and then to examine yourself that how much you have gained from the week from listening all the episodes of my podcast throughout the week. Well, if we just throw light what we have done from Monday to Sunday, it's not a very big thing. We have actually covered one heading in detail because daily we do some part of it and then it becomes one whole topic through the whole week. So we are starting from this week's topic, and it was in detail we have covered this week totally about plasma protein binding. Now, Monday, what we did was the introduction to the plasma protein binding, and let's get to summarize what we have done in the podcast episode. It was actually what I'm going to tell you now. Drugs usually bind to the plasma and cellular proteins in a reversible manner, and I told you they always stay in a dynamic equilibrium. And the equation which I gave you was very simple, though it's very important equation. If you understand and go through it again and again, you'll understand the whole basic concept of plasma protein binding. And that is free drug plus protein gives the drug protein complex, and this is a reversible equation, and this stays in equilibrium. So extensive protein binding results in the blood, which serves as circulating drug reservoir. So excessive protein binding leads to a sort of storage room for the drug. But as I told you, it's only the free form of the drug which is the active form. So that should be taken care of, and that determines the whole thing because it is only available for action, metabolism, excretion, and other activities. It can only diffuse through the capillary wall, also through the blood-brain barrier. It can be metabolized, excreted through the glomerulus, saliva, CSF, milk, etc. The protein bound component is not at all accessible to capillary diffusion, metabolism, or excretion. It's the free or the unbound form of the drug which is eliminated from the body. Then more drug dissociates from the drug plasma protein complex to replace that free drug. So extensive protein binding does not prevent the drug from reaching its site of action, but only what we get in result is a prolonged duration of action of the drug, and association and dissociation is usually very rapid between the drug and the plasma protein. Then we have then I told you about the different types of protein, and first of all which we discussed was the most important one, that is albumin. So I told you that generally in general it is the most important plasma protein which binds so many drugs, and it is the one which binds mostly the acidic drugs, though it still binds the basic drugs, but for the basic drug it has a high capacity but low affinity, so it releases them very easily. So in nutshell, we don't gain anything for the basic drugs, but what we get is for the acidic drugs because it has a net negative charge. So for the acid drugs, it binds them very strongly, and it has low capacity but high affinity for the acidic drugs. So it is the most important contributor to the drug binding, and acidic drugs like warfarin, then we have penicillin, then we have sulfonamides, tolbutamide, salicylic acid, they all bound to it avidly. Then the next one which we discussed was alpha-1 acid glycoprotein, abbreviated as alpha-1 capital AGP. Now, acidic drugs, they bind to albumin, and similarly, the basic drugs, they bind avidly to alpha-1 acid glycoprotein. And these are the quinidine, imipramine, lidocaine. Then we have chlorpromazine, propranolol, its analogs. Then we have spiroperidol. So, the plasma alpha-1 acid glycoprotein is also known as the acute phase reactant. Now, why it is told as the acute phase reactant protein? Because its concentration in plasma rises, especially in the condition of pathological diseases and states of physiological stress. Now, the pathological diseases in which it rises condition is the myocardial infarction, arthritis, Crohn's disease, and physiological stress conditions also. It leads its concentration in the plasma, it rises. So it is an acute phase reactant protein. Then we have other binding proteins in plasma. These are the tissue proteins. These are the nucleoproteins, and examples I gave you along so that you can understand and get the whole picture very clear in your minds. Some drugs, especially having high apparent volume of distribution, they specifically bind to tissue proteins, and they are digoxin, emitin, and then we have chloroquine. And then we have, lastly, I discussed about the miscellaneous binding proteins. In this, I covered three proteins: the corticosteroid binding protein, that is transcortin. Then you have gamma globulin, to which the immuno antigens bind, and then we have alpha globulins, to which the thyroxine binds. So that is an important example. Now there is no use of learning the names of these proteins if you don't know the examples. So first learn the example, and then automatically you will get to know it binds to which plasma protein. So that's the trick, and that's how you have to progress while you are learning. So never, never, never miss the examples. Next topic we had was the clinical important aspects of plasma protein binding. In that, the first one we discussed, the first day that we discussed, was the high plasma protein binding leads to the drug to remain more of the time in the vascular compartment, and then it tends to have a lower volume of distribution. Now, that is a very important aspect, and that is the most important clinical aspect of plasma protein binding. Then these drugs which are highly protein bound, they are not easily removed by dialysis, that I told you, and for that you have to use some special techniques in case the poisoning of these drugs occurs, because they are very strongly bound to the plasma proteins, and dialysis is generally ineffective in such cases. Then next I told you was that plasma protein makes the drug very long acting. So that is another important clinical aspect of plasma protein binding. The next day we discussed about the displacement drug reactions. Now the basis of these displacement drug reactions was again plasma protein binding. Now more than one drug can bind to the same site on the albumin. I told you that especially albumin. I was talking about albumin in my episode also. So you have to take in mind that it's the albumin which has on it many drugs bind on different sites, and one drug can bind to the same site. There are many 2 or 3 drugs can bind to the same site on this particular molecule. So all this mess leads to a lot of displacement drug interactions, and though you don't need to worry about much, because only few of them are really significant and which may cause a state of worry or a state of really poisoning or toxicity, only in 2 criteria which I told you. The first one, if it is 99%, more than 90% plasma protein bound, because if it is so highly bound, then the free drug concentration increases exponentially, and that may lead to toxicity. The next one I told you, next criteria was it is not extensively only bound, but it has a smaller apparent volume of distribution, and that is the most important thing. So the 3 examples I gave you for this particular thing was warfarin, tolbutamide, and phenytoin. And so you have taken account all these conditions when you are talking about the displacement drug interactions and how they are clinically important aspects of plasma protein binding. And lastly, I told you that it is not a big problem with the basic drugs because they have a high apparent volume of distribution. That is a very important fact about them. and they bind to the different loci than the acidic drugs. That also makes them quite safe. No displacement reactions when the drug is bound to a different loci, then there hardly any displacement reactions occur in such a condition. Then the last day we talked about the plasma protein binding clinically important aspect, which was relevant, which we need to talk about, was the disease state. The disease state, it however modifies the plasma protein binding, like I told about, especially in liver diseases and in kidney failure. I talked about hypoalbuminemia, and because of this, I told you albumin is the most important plasma protein to which most of the drugs bind. So when it decreases in concentration, then definitely the free drug concentration increases, and it may lead to toxicity. And similarly, in the conditions when I told you in pathological states and in physiological stress, acute phase reactant protein, that is alpha 1 acid glycoprotein, increases. So basic drugs are bound more to it. So that may also lead to altered plasma protein binding from the normal states, and that may have clinically important aspects which you need to take care of. Then lastly, I told you that it is both the bound and the free form of the drug when you are referring to the drug in vitro, and when you are referring to the MIC, that is minimum inhibitory concentration of an antimicrobial. Then what you're talking about is both bound plus free form of the drug. It's not a simple free form of the drug. So that is the thing you need to take care of when you're talking about the MIC of an antimicrobial, or you're talking about the drug amount in vitro. And today, Sunday, what we did in the podcast, or in case it's not on air, you will be soon getting my episode. It will be about the apparent volume of distribution, which I was giving teaser from the last week in so many of my episodes, and today we are going to talk about it. So it's the apparent volume of distribution, and what is it exactly, what is the background, and what is the definition. We're going to derive about it, and why it is known as apparent volume of distribution. I'm going to tell you whole in today's episode. So this is just a revision. This is not in details as much as my episode, but yes, you can just get an idea what we did throughout this week. So just to wind up today's podcast session, let's talk about apparent volume of distribution. Distribution does not represent the real volume of distribution. It must be regarded as the size of the pool of body or of the fluids that would be theoretically required if the drug was distributed equally throughout all the portions of the body. So that is the most important thing, and that is you have to take care of. It is the total space which would apparently be available in the body to contain the known amount of drug. So for the details, you should go and listen to my podcast, because it will give you the whole crystal clear picture of this thing. And with this information and definition, and I won't be giving you much more details here, it's just a revision and summary of the whole week that we did. So these are my links, and this is the website that you can go through to listen the details of each episode weekday wise. I hope you all like this endeavor of Week in Classroom, and it would be of some benefit to you in case you just need a summary of what we did the whole week. So it's all the summary of a short summary of compilation of all the topics we did throughout the week. Nothing more than that. For the details, you have to definitely listen to my podcast on ispharmacologydifficult.com, and I'm also various links of Twitter, Facebook, LinkedIn, and Instagram have been given here, which you can always go to and refer for more resources, details, and updates. Till then, thank you, take care, bye-bye.